I'm welcoming you to this workshop. We're going to be talking about treating depression in adolescents, and specifically we're going to go through and introduce you to the approach that was used in TADS, and then with some modification in Tordia. If you were at the talk yesterday, I talked about some of the results of those two studies. And toward the end of the workshop tomorrow, I'll talk about integrating medication and CBT in the treatment of adolescent depression. But today and tomorrow morning, it'll all be on the CBT protocol. We do have internet access in the room. You don't have to do this to do the workshop, but if you have a computer with you, you'll be able to pull up the TADS manual online. But I brought some handouts that go through sections of it that we'll do in the workshop. The manual is available to the public. That was part of the whole idea of TADS, was that we would make everything available to the public after the trial, because it was funded by your tax dollars at work. Sometimes taxes are okay, I guess. They have some good benefits. Okay, so I don't have any financial relationships to disclose. I couldn't get a direct flight, so I was a little delayed coming here because I had to go through. I love this cartoon. This is my hobby. I read through the New Yorker cartoons and pull out stuff that I like and then try to find somehow to work them into a talk. But anyway, I guess we should get Wendy to come in here and kind of demonstrate this, right? I told her I was throwing out all my cartoons and just going to ask her to do them. Anyway. Okay, so now the challenge when you give a workshop on depression, especially when it's a beautiful sunny day in Miami and we're in this closed room with no windows and we're talking about depression. Jeez. So I'll try to keep it, on the upbeat. But I do have to talk about what depression is a little bit. And the reason for this is that in your practice, the first thing you have to decide is whether this treatment is suitable for the case you're dealing with. And this is not easy. I think this is not an easy decision. We, in doing training workshops in different places with clinicians and in my own practice, it's not always clear whether somebody is depressed, whether a kid is depressed or something else, or depressed plus something else. You're going to see, of course, and you do see a lot of kids who have disruptive behavior problems, and that's why they get referred to you. And they may or may not be suitable for this. I mean, this is really for people that have a primary depression. That means the depression is the main thing that needs to be addressed, okay? So I had an email from a clinician, this is about 2 weeks ago. A woman wrote to me about this treatment, and she was asking questions about, who is it suitable for, and she's working in a school system, and she has to develop and implement treatments for, of course, all kinds of problems, but she asked me why, if the kid is on the verge of being thrown out of school for behavior problems, is this a good treatment for that? And I had to say no. I mean, you have to treat, because if he's on the verge of being thrown out of school, then the primary problem is a disruptive behavior, presumably. Okay, so that's what I mean, and that kind of thing comes up all the time. So I want to spend a few minutes talking about who this is for. Okay, so what do we mean by depression? There's three meanings, at least. One is that it's just a feeling, maybe a symptom, but maybe just a feeling. So if your dog dies, you feel sad. And some people would call that feeling depressed or blue or down in the dumps. And that's just a normal human emotion. That is not a disorder, right? If the sad feeling then is accompanied by other symptoms like loss of interest or fatigue, then you have kind of a cluster of symptoms, which is called a syndrome, and that might be something that would warrant intervention. It might, depending on how long it goes on, how severe it is. And then the third meaning is a disorder. And this is the meaning that is used in psychiatry and for the most part in clinical psychology. And a depression as a disorder means not only is there a set of symptoms, but also they are severe enough to interfere with functioning, and they go on for more than an expected amount of time. So a disorder is a set of symptoms with severity and duration. And theoretically, at least, the disorder is supposed to have an expectable course. I don't think you can really say what the expectable course is for depression very well because it varies so much. I'll show you some slides on that. But also a significant change in the child's functioning. So as a clinician, that's what I rely on. I ask the parents and the kid if they have had problems in school, or they've had problems with friends, or they've had problems with more conflict at home, or something in the, in the real world functioning of the child. And I showed this slide yesterday, but just this is where depression fits in the current DSM, the DSM-4. You've got unipolar depression and bipolar affective disorder. So under the depressive disorders, major depression, dysthymia, and the kind of residual category, depression not otherwise specified. Those would be the kids for whom this is a suitable treatment, kids who have those depressive disorders, okay? This is not a treatment for bipolar disorder. There are, of course, bipolar disorder, if it's really bipolar disorder, which we could talk about if you would like to talk about that, does require medication, but there is a family-focused therapy for bipolar disorder to help families and kids to comply with treatment and work on the psychological aspects of the disorder, and also on the depression, which is, I found out not too long ago. I mean, I should have known this, I guess, but you always should have known something. I didn't realize that bipolar patients spend much more of their life in depression than in mania. So there are treatments for that, but this one is not specifically for that. And so here are the symptoms that you need to ask about, and we're going to go through an example of how to ask about these. These are the symptoms of major depression: mood disturbance, loss of interest or pleasure. Those two are the key. If neither of those is present, this is not depression. Might be something else, but it's not depression. These are the kind of the gateway symptoms. They have to be there. One of them has to be there. Depressed mood or irritable mood, or loss of interest or enjoyment. And then you have the physical symptoms related to eating, sleeping, movement, psychomotor agitation or retardation, energy, and then the cognitive symptoms, guilt or worthlessness, trouble thinking or concentrating, and suicidal thoughts, plans, or attempts. Okay? These are of some interest, but I don't think we need to go into them in great detail, except to say that there is psychotic depression, and psychotic depression is going to need medication for sure. So if you have a patient who has delusions of guilt, where they really do believe that they're responsible for some terrible event for which they are clearly not responsible, then you have psychotic depression. And if you work in an inpatient unit, you will certainly see this. I didn't see it until I did work in an inpatient unit, which was, about 8 years after I got out of graduate school, I started to work in an inpatient unit. Okay, so Now, the second problem for which this might be an appropriate treatment is dysthymic disorder. I don't have any studies to show you that this might be an appropriate treatment. So there are very few studies of dysthymia, the treatment of dysthymia. But dysthymia is a milder but longer depression. It lasts for at least 1 year in children, 2 years in adults, where the person's mood is depressed or irritable most days, and they have at least a couple of other symptoms that are the ones listed below. Okay? Now, the dysthymia is actually harder to treat than major depression. It does not, it's just a kind of a prolonged, difficult mood problem that sometimes it's hard to tease out if it's the person's mood or just their personality that's so ingrained. So dysthymia is very hard to treat. There are very few treatment studies of it. But I think that this would, as far as we can tell, this kind of a treatment would be an appropriate thing to try for dysthymia. Here's the example of, am I a happy man or just an asymptomatic one? Okay, so this guy might be dysthymic, but he might just be kind of a disgruntled guy. I don't know. I don't think I would want to take him into treatment at this point. Okay, the prevalence of major depression and dysthymia. This is a study from the early 90s in Oregon with high school students. And point prevalence means that at the moment of the interview, the person had the disorder. And lifetime prevalence means sometime in their life they report having had the disorder, okay? So the point prevalence that Lewinson's group found for major depression was 2.5%, but they found a very high lifetime prevalence among high school students who, so the way to remember this is by age 18, 18% is what they found. So other people have found lower numbers. This is kind of on the high end. Dysthymia, as you can see, is much less common. Only about 0.5% of high school students have it at the time of interview, and about 3% report having had it. This is a slide I showed yesterday that combines a lot of studies on prevalence. And the interesting thing is the age difference and then the gender difference. Okay? So you get much higher rates of depression in adolescents than in children. You know, this is one of the reasons that in the old psychoanalytic model from the 60s and earlier, we didn't recognize that depression existed in kids. For two reasons, I think. One reason was the theory that, you know, in order to get depressed, you really have to be able to beat up on yourself, and you can't do that until your cognitive development is at the adolescent level. But also, clinicians just didn't see it very often, okay? So it's not unheard of in children, but it's, you know, not common, whereas in adolescents it becomes much more common. And the presentation seems to be a little different, especially suicide attempts. Lethal suicide attempts are much more common in adolescents than in children. It's very rare for a child to commit suicide, but it does happen. But you know, the rates are thankfully low. And then the gender difference that everybody's tried to figure out, and so far we haven't quite figured it out, but in children, when there is depression, there's no gender difference. Boys and girls are equally likely to have the problem. But in adolescents, from about age 14 on, depressed females outnumber depressed males, in some studies as much as 2 to 1. It's not quite that much overall, but it's sort of like 3 to 2 in the Jane Costello review. But it's much more common in girls. It usually lasts for somewhere between about 9 months and 12 months, major depression, but sometimes much briefer. Dysthymia, on the other hand, look at how long it lasted in these kids that Kovacs studied. 4 years was the average duration. That's like half the kid's life. And both of these groups had, had a high risk of a second episode over the next 9 years. Now, here's why I said earlier it's hard to say what the expectable course of major depression would be, because Lewinson, in that study of high school kids, he found that the average duration was 26 weeks, which should be 6.5 months, but the median was only 8 weeks. So here you go, stats 101. What's the difference between a mean and a median? Who remembers what a median is? Okay. The midpoint, right. So if you take all the kids and you just look at the if there's 100 kids and you look at where the 50th kid is, that's the median. So in terms of the number of children, most of them, half of them only were depressed for 8 weeks. So the mean is being pulled up by some people who are depressed for much longer than 26 weeks, okay? So the mean, if it's 26 weeks, there's some groups, there's some people in there that got it for a long time, right? And you see that kind of pattern all the time when you look at this issue. And look at the range of duration, from 2 to 520 weeks. 520 weeks, otherwise known as 10 years, right? And he found 33% who recovered had another episode in 4 years, and that things were worse if you had your first episode before 15.5 years of age. So, you know, I don't know whether you experienced this, but when I went into child psychology, one of the reasons I went into child clinical was I thought, hey, we can get these problems early and take care of them, right? It would be easier. And the developmental histories were shorter, so that was nice. Okay. But, you know, I found out soon enough that if a kid has a problem that early in life, it's usually a more difficult problem. But anyway. In the group that I talked about yesterday, the TADS group, the 439 kids, the average duration, the mean was 70 weeks and the median was 40 weeks, okay? So if a parent asks me, how long is it likely that my teenager will stay depressed, the only honest answer I can say is that there's a tremendous variability. The average is about, in most studies, the average is about 9 months, but there's a tremendous variability, and you just don't know. On the other hand, the chances that they will recover within a couple of years, within 2 years, are very, very high if it's major depression, like 85%, okay? And it does lead to risk for adult depression, as we talked yesterday. Now, this is something I didn't talk about yesterday. There is a risk for bipolar outcome in depressed people, okay? So if you're seeing a young person with adolescent depression, major depression, there's some risk that they will develop bipolar disorder. The risk is not, it's not that high in most samples. In most outpatient treatment samples, the risk is about 6 to 8%. So somewhere between 6 and 8% of the kids who come to you for major depression and never had bipolar disorder will develop mania later, okay? And if you work in an inpatient setting, the rate is going to be higher because you're seeing more severely depressed people, okay? The predictors are these ones at the bottom. It's more likely to develop bipolar disorder if the depression started in childhood as opposed to adolescence, if it was psychotic depression, if they became a little bit manic when they were put on medication, antidepressant medication, and if there's a family history of bipolar disorder. So it means you have to watch for it, basically. Okay, now, as you know, when you see a kid with the depression, and this affects the treatment planning we're going to do in a minute, they often have another problem, frequently a conduct or oppositional disorder or an anxiety disorder. So you have to decide what you're going to do about that. Okay? With adolescents, you also get substance use disorder. Okay? And this I mentioned yesterday in terms of the sequence of disorders. Okay, so I'm going through these quickly because I want to get to the treatment. So now here's the first task in deciding whether to use this treatment is to do a diagnostic workup, obviously. And these are some of the things that I would recommend you use in a diagnostic workup. First is a regular clinical interview, kind of an interview you routinely do with people to get to know them and to get their statement of the problem and when the problem started and what things might have led to the problem and so forth. So I would not abandon your routine practice of doing a clinical interview. It's very important, and the other instruments supplement it, but they don't replace it. Then I would do a semi-structured diagnostic interview. I'll talk to you about one of them. This also is available online if you want to look at it. It's kind of an overwhelming interview, but you don't need to do all of it. But it's just a way of asking people if they have the various symptoms of depression and the other things that often go along with depression. Okay. Then I would use a questionnaire. I would at least use a depression questionnaire, like the BDI is the Beck Depression Inventory. The RADS is the Reynolds Adolescent Depression Scale. The CDI is the Children's Depression Inventory. I don't know why I put all these abbreviations in there. The BHS is the Beck Hopelessness Scale. Hopelessness is important to evaluate when you start treatment. And the next three are cognitive scales: the Dysfunctional Attitude Scale, the Automatic Thoughts Questionnaire, and the Children's Negative Cognitive Errors Questionnaire. And then we often use the FAM, the Family Assessment Measure. But I think the key ones, if you have to be economical in your assessment, I would use either the BDI or the RADS with adolescents to get their self-reported depression, and the Beck Hopelessness Scale. Okay. And then a rating of depression severity. Now you may just want to use this instead of the diagnostic interview, or in place of part of the diagnostic interview. I'm going to show you the Children's Depression Rating Scale, which you have a handout of. Now, some of these measures are published measures, so if you're going to use them, you have to buy them, including the Children's Depression Rating Scale. That's published. I just made a copy of it for the workshop, but it's available from Western Psychological Corporation or whatever. I forget the name of the company, Western Psych. Okay? So, why do an unstructured clinical interview? Well, I think it's important, although not everybody agrees with me on this, but I think it's important to let people tell their story. If I go to a psychologist or a psychiatrist with a problem, or even if I go to a dermatologist, I had to go to a dermatologist for a problem, I want to tell the person what I'm upset about. I mean, I don't want to just have them throw a bunch of symptom questions at me. Not at the beginning, anyway. You got to establish rapport, and you have to understand the person's concerns. Secondly, doing this kind of an unstructured interview helps them to figure out why they're feeling bad, like what's happening in their life that's making them feel bad. And I would structure it enough that you cover, your typical intake areas, like family, who's in their family, their peer relations, if it's a child or adolescent, their school, situation in their activities and interests, and some strengths. Okay, so I always ask kids, or at least I try to always ask kids what they like to do, or what they do well in school, stuff like that. You don't want to focus the whole thing on negatives. Now, another thing that I use in my own practice, which I would recommend, is a developmental history form. This can be given to parents to fill out in the waiting room while you're talking with the kid, or they can take it home and bring it back to you. This is something that actually I learned from one of the 6 guys named John at Duke in the mid-'80s. His name was John Fowler. He was a psychoanalyst. And he taught us that the developmental history is the most important part of the workup, because it's going to tell you how far back this problem goes, what started it, what the child's temperament was like, what kind of medical problems they might have experienced. And you're really going to get a lot out of it that you'll use going forward. So, you know, now I use the one that's listed second. It's called the Child Neuropsychological History Form. It gives information on what the child's early temperament was like, whether there were any problems around birth, delivery, the neonatal period, their developmental milestones, how they did in school, medications and psychological treatments, and family history. It's all on this one form, and you know, it doesn't take parents that long to do it. There's also the one that Keith Connors and John March developed, which is similar. It's a little less neuropsychological in its orientation, but it's pretty good, and that's also available. These are both published forms, so you have to buy them. Okay, so now let's go to the interview. Your question in doing this interview is, does this person have depression, either major depression or dysthymia? And also, what other comorbid conditions do they have that I'm going to have to deal with in the treatment? So it may be anxiety disorders, or it may be disruptive behavior disorders, okay? And it may be, and you also have to at least screen for mania, because they might have mania, hypomania or full mania. Now, a semi-structured interview differs from an unstructured interview and a structured interview. So a structured interview is like what you got when you answered the door for the census takers. Anybody did you get a census? I had a guy, I mean, first of all, we got the paper form. We filled out the paper form, but then this guy comes up to the house and wants to know about who lives next door, because he couldn't find the woman that lived next door, and did she really live there, and blah, 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 blah. So then he asked me, like, how old is she? I don't know. I had to guess, like, how old is she, and does she live there all the time? And it's all these yes, no, and kind of objective answers. That's a very structured interview. So if you ask somebody, do you have sleep problems? Yes, no. That's a structured interview. A semi-structured interview is more like, tell me about your sleep. And the person then describes that sleep pattern, and you, as the clinician, decide whether they have a sleep problem, whether it's taking them too long to fall asleep, whether they're waking up in the middle of the night, or whether they're waking up early in the morning. And you can use as many probes or as few as you need to make the rating. So if you do look at this K-SADS interview that's online, it has a lot of different probes to ask kids if they have depressed mood, which is the first item on the questionnaire. Now, of course, I would never ask somebody all of these questions. They'd think I was out of my mind, right? I mean, I'm just going to ask them a couple of them to get a sense of how they've been feeling. So have you ever felt sad, down, blue, down, empty? Did you feel that way all the time or some of the time? Did it come and go? And then, based on what the teenager tells me, or what the parent tells me about the teenager, I rate whether they've got the symptom or not. That's what this part is here, okay? So, you know, you can use a 3 as your cutoff if you want, or a 2 if you want to use 2 as a cutoff. In all the studies that I've talked about yesterday, they used 3 as a cutoff. So they had to feel depressed most of the time to get that symptom, okay? You don't give up your clinical expertise by doing a semi-structured interview. You have to adjust it for the child. If you're working in a bilingual setting, you have to know phrase this for people that use a different language. You have to know enough about the way they describe these things in their own language so that you can make a rating. Okay. Okay, and while you're doing this, you try to get a timeline going. We're going to talk about timelines a bit later, including some sense of when this problem started. When did they start to have this depression? Okay. With teenagers, you usually do the interview with the adolescent first, and then you ask the same questions of the parent about the adolescent. With children, you usually ask the parent first and then ask the child, because parents have a better sense of time than children. Okay. And I don't know what you do when you do evaluations. I mean, we could talk about this some. I always, with teenagers, I always bring the parent and the teenager in the room first initially, because I want to get them to say what the presenting problem is in the presence of the other person. I don't want the parent coming in telling me what the problem is, and then the kid comes in trying to guess what the parent's already told me about. Okay, so it's easier for me if I just have them both in the room to begin with, and then I send one of them back to the waiting room. Okay. So this is the way the whole interview goes. One advantage of this case-ads is that it screens for all the disorders first before going into detail. So if the person doesn't have any symptoms of the problem, you don't have to bother with it anymore. So that cuts down the time involved. But it covers mood disorders, all the anxiety disorders, psychosis, eating disorders, the disruptive behavior disorders, attention deficit disorder, attention deficit hyperactivity, oppositional and conduct disorder, and tics. It also includes substance use disorders. Okay? All right, and these are the screen items. I'm not going to labor this, but these are the items that are included in the screen part. You can see that if a person doesn't have any of these items, the chances of them being depressed are virtually nil, so you don't go into any more depression question. Okay? These are the questionnaires that I talked about. Now, I want to do a little bit on the Children's Depression Rating Scale and show you how this is done. And I gave a copy of it to you. So if you can pull that out, we're going to look at a video. Can we get up the DVD? Do you have that? This should be I hope this is at the beginning of the DVD. This is a semi-structured interview that goes through both functional things like schoolwork and symptoms, okay? It's suitable for ages 6 to 12 and also for adolescents. It covers 17 items, and you have it there in front of you. On any item, a rating of 3 or higher is considered to be a symptom, okay? It uses a short time frame, either 1 week or 2 weeks. You can use it for either 1 week or 2 weeks. And the questions are arranged so that the easier things for people to talk about are first, and then the harder things come later. Okay? All right, so now this is not a patient. This is one of my graduate students. If you work with me in graduate school, you get subjected to this kind of indignities where you have to role play for tapes, but okay. Hi, Jackie. How are you today?
I'm all right.
You all right? Yeah. I know we talked a little bit last week about how things have been going, and wondered if you're still feeling pretty much the same way as you were? Okay. So what I need to do today, if it's okay with you, is just kind of review the symptoms that you've had to see how they're going. That's how they've been. I'm just going to ask you about how they've been in the last 2 weeks, okay?
Okay.
So, what grade are you in school?
10.
10th grade. And how are things going for you with your schoolwork?
I mean, they used to be really good.
Mm-hmm.
Now they're, I guess, so-so.
So-so?
Yeah.
So have your grades gone down at all?
Yeah.
From what to what?
From like A's to maybe B minuses.
Okay.
I get by, but I'm not
Get
really
by.
doing much work.
Okay. Is it, are you having trouble with all of your subjects or just some of them?
I'd say most of all, yeah.
Most all of them, okay. And how much trouble do you have like concentrating when you're sitting in class?
Well, that's the problem.
That's
yeah,
the problem.
I'm not focusing at all.
Not
I'm not
focusing.
focusing in class, and then I'm not focusing. If I try to do homework, I just don't even bother anymore.
You don't bother? Okay. And this is different from the way things were before?
Yeah.
Okay.
I used to work hard.
Okay. Do you feel like you don't bother at all, or are you still trying some, or what?
I do enough to get by. So I mean, like, I do the homework maybe right before class and give it in, as opposed to
Okay.
like the hours I used to put into it.
Okay. Okay. Now, outside of school, what sort of things are you doing for fun?
I'm not really doing anything now.
Nothing? Did you have things you used to like to do?
Yeah.
What were some of those?
I used to play softball.
Mhm.
I used to be part of the drama club and the yearbook.
Oh, okay. So you were in quite a few things. And when did you stop those things?
Maybe a few months ago.
Okay. Okay. And now, in the last 2 weeks, have you been doing anything at all that's enjoyable?
Sleeping.
Sleeping? That's the main thing?
Yeah.
Okay. No work on the drama club or any of that stuff?
No, I mean, I've gone to a couple of meetings, but I haven't done anything for it like I
Okay.
usually do.
Okay. Do you feel bored a lot?
Yeah.
Okay. So when you went to the meeting, what was that like? What was the experience like?
I just kind of sat there. I was just
Mhm.
there. I was
Mhm.
there to be there.
You were there to be there. Okay. All right. Are your parents concerned about this?
Well, yeah, that's why I'm here.
Okay, so what do they do about you? The fact that you've stopped doing some things, what are they doing about that? Anything?
They try to say something like, you
Uh-huh.
should go do this, or hey, there's
Okay.
that thing today, you should go. But
Okay.
I mean, they can't make me go.
No, okay. All right. Okay. How about with your friends? What are you doing with your friends?
Well, those were a lot of the things I did with them. I had friends through that,
Mm-hmm.
so not much.
Not much. Okay. Do you have friends?
I think so. I mean, the
Okay.
people through that stuff, like yearbook.
Yeah. Okay. And did you used to do more with them?
Well, yeah, we would go around and take pictures together,
Mm-hmm.
or we would like rehearse for the shows and such.
Mm-hmm. Okay. How about on the weekends? Would you see them on the weekend?
Sometimes, like movies or something.
Okay. And in the last 2 weeks, have you done any of that?
No.
No, nothing at all. Okay. Have you done anything with friends in the last 2 weeks?
I made plans with one, but then it just didn't work out.
Okay. Have people invited you to things that you didn't go to?
Not recently.
Not recently. Did that happen before?
No, before I think I was invited more, and then sometimes I would go, and then it started slowly. They would still invite me, and then I just didn't want to go, and feel like it, and then they stopped asking.
So then they've stopped asking you. Okay. 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 I want to ask you some things about sleep and eating and energy. How has your sleep been in the last 2 weeks?
That's what I've been doing a lot of, so I've been sleeping.
Doing a lot of sleeping. Okay. So let's go back to how you were doing before you started to feel bad. What was your typical sleeping pattern?
Probably 8 hours.
8 hours? What
Yeah.
time would you go to bed?
Probably like 11.
Okay. And you
10,
get up
11.
around 7 or so?
Mhm.
Okay. Now, in the last 2 weeks, what time have you been going to bed?
Well, it's on and off because I nap a lot, so
Mhm.
it'll be like I'll go to bed at maybe 9. Like, I'll go to bed still 10, 11 maybe, but
Mhm.
when I get home, I'm going to bed. So I'm napping for a long time, and then basically I'm just waking up for dinner,
Okay.
and then I'm going back
And then
to
you're
bed.
going back to bed. And then how long do you stay? Do you go to sleep when you go back to bed?
Yeah,
Okay.
yeah.
And do you sleep all the way through till the morning?
I'm probably wake up here and there, but not for very long.
Not for
Still
very
stay
long.
in bed.
Okay. So it's not hard for you to fall asleep?
No.
And in the middle of the night, you just wake up here and there
Yeah.
for a few minutes?
Maybe, yeah.
Okay. And how about, do you ever have the experience of waking up real early in the morning before you plan to wake up?
Not usually. Or so I wake up and then it's just really hard to get out of bed, so I'll lay around for a while.
Okay. Now let's talk about your appetite. Have you noticed, compared to the way you were eating maybe a year ago when you were feeling okay, has there been any changes in your appetite?
I guess. Well, yeah, I guess my parents have pointed that out. Yeah, I
Mhm.
guess I'm not eating as much, so I guess I'm not as hungry.
But you sounds like you hadn't noticed that yourself. Somebody, they pointed it out. So let me, before we talk about the ratings you gave the role play patient, look at item number 15, 16, and 17, the last three items. The way this interview is set up, the first 14 items are like a verbal interview, but the last three items are things that you rate from observation. Okay, so if you had to rate her for facial affect, whether how expressive she is in a range of affect in her face versus kind of restricted or constricted, go ahead and give that one a rating. I'm going to do this too and see what. And then the next one is for speech. Now, this is more to pick up psychomotor retardation. Is the speech slow, monotone, too soft? Does it get to the point where there's actual delays in speech? I don't know whether you've interviewed people that really have psychomotor retardation. When they really have it, it's quite striking. I mean, it's like painful to get an interview going, So that would be like, a 5 on this particular item. But, you can say what you think about her speech, and then body movements. We didn't get to see much of that in this, but you can kind of guess whether her body movements are somewhat restricted or slowed or not, okay? So let's just talk about these few items and see what, how people did on we'll do a inter-rater reliability thing here, okay? So let's go to item number 1. How many, this is for impaired schoolwork. How many people had 3 or below? Huh? Below 1. 3, 2, or 1. Did you have a 3, 2, or 1? Okay. And then how many people had a 4? 5? 6? Okay, so anybody have a 7? So the group is somewhere between 4, 5, and 6, okay? Because it seems pretty clear that there's some interference with school. She says her grades have gone down a little bit, and that she just doesn't have as much motivation to perform as she used to. So that's right. It would be somewhere in that 4, 5, 6 range. How about the second one is for anhedonia, difficulty having fun. Did anybody have a 3, 2, or 1? 4? 5? 6? 7? Okay, so it's 5, 6, 7. You see the ratings are a little bit higher on this one. I had a higher rating on this one too. I had a 4 and then a 5, but you can see the range. We're in the same range, and the range is a little higher on this than on the last one. How about social withdrawal? Anybody have a 1 or 2 or 3? Okay, 4, 5, 6, 7. So only a range of 2 items. Very good reliability, gang. There you go. All right. So 5 or 6. All right, and then sleep disturbance. I had a hard time with this one. I had a hard time when I was doing the interview, and I have a hard time every time I look back on it. I can't figure out how to rate this one. But the problem is that this scale does not include hypersomnia. It only includes insomnia. So it kind of leaves you hanging when somebody's got hypersomnia. So I just rated it a 2. I couldn't figure out what to do with it. And then I didn't fill out the supplement because it wasn't insomnia. Appetite disturbance, anybody have a 1 or 2? 3? 4? 5? So primarily 3 or 4, okay? And it was decreased appetite. And then if you go to the observational items, facial affect, listless speech, and hypoactivity, I rated them 4, 2, and 3, although it would be a lot more informative if we had seen her walking into the room and, moving a little more. So I was kind of guessing on that. All right, so anyway, I wanted you to get that experience just because those are the things you have to attend to if you're going to decide to use this treatment. Do they have depression? And if you're getting nothing on any of those items, then this doesn't look like a good treatment for the person, okay? Now, do you understand why she's depressed? I have no clue why she's depressed, okay? That's the problem with the semi-structured interview. It's not going to tell you why. So you have to do the unstructured part and really get to know them. Okay, these are the other items on the scale, which I'm not going to go into in more detail. So now let's just finish up this part before the break so we can start on the initiation of treatment after the break. This is the medical model of depression. I don't care. I'm kind of agnostic on this. I don't know whether it's a disease or not. It doesn't rise to the level of a disease that bipolar disorder does. So it's kind of murky, And these are some things that you would look for if you were going to try to establish whether it was a disease or not. Now let's get to the cognitive behavioral model of depression. As I mentioned briefly yesterday, there are 2 models that have guided treatment for adolescent depression, and it's important for you to know these if you're going to use this treatment because they will help you do the case formulation. The Beck theory is that depression is a disorder in thinking. His view is that a person who is vulnerable to getting depressed has a basically negative view of the self, which is that they are somehow inadequate or defective. They also tend to have a negative view of the world as being too demanding, unreliable, hostile, unsupportive, and a negative view of the future, hopelessness, okay? What happens when such a person gets stressed is that they start to have automatic thoughts that are negative and that reflect underlying cognitive attitudes and beliefs. So if you take a teenage boy who is walking down the hall in school and says hello to a girl that he's attracted to and the girl doesn't respond, okay? This is hardly a rare event, it does happen. A negative automatic thought would be, she ignored me. How else might you interpret that besides she ignored me? She didn't hear me. She didn't see me, okay? But a negative automatic thought is, she ignored me. Now, that's what you're going to pick up first when you start to do the treatment. You're going to hear all these negative automatic thoughts coming out, and you just keep track of them, okay? Then you're going to start to work on them. Beneath the level of the negative automatic thought is the dysfunctional attitude, which would be something like, she must like me, Unless she likes me, I am unlovable. So it's a conditional thing. Unless she likes me, I am unlovable. And that reflects a core belief like I am unlovable, okay? Another common adolescent experience is not doing well on a test in school, okay? So the kid bombs out a math test, and she comes in, and what are the negative automatic thoughts we hear from adolescents about that? Huh? I'm stupid. I hate math. I'm no good at math. I can't do math, right? The dysfunctional attitude you could assume would be, unless I do well on every test, I am stupid. And the core belief would be, I am incompetent. I am incompetent. It's a competency belief, okay? What maintains these negative core beliefs? Why do people keep hanging on to these negative core beliefs even when they're harmful to them, okay? One thing is that kids are developing their self-concept, their self-schema, and it's still pretty limited. I mean, they haven't had that many life experiences yet in different areas of life to get a differentiated self-schema. So they focus too much on the area of weakness, or their area of weakness. For example, think of something you can't do. Okay, now I cannot draw. I just can't draw, okay? What difference does it make? It doesn't make any difference. Therefore, I don't get depressed about it. But if I went to a school where I had to draw all the time, I would pretty be bummed out, okay? I can just say, well, I can't draw, but I can do other things. Because my self-schema has more than one area. You know, drawing's not a key part of it. You can apply that to anything that you feel that way about yourself, okay? The second thing that keeps these negative core beliefs going is the cognitive distortions, which are probably the most well-known part of Beck's model. The black and white thinking, I'm either brilliant or stupid. I either get everything right or I get everything wrong. Or discounting the positive, not paying attention to positive things that happen. Yes, I bombed out a math test, but I did really well on a history test. Well, the history test doesn't count. Why doesn't it count? I don't know. It just doesn't count. Okay. Making the relative absolute. That girl absolutely, positively must say hello to me. Okay. Or overgeneralization. That girl didn't say anything to me, so no girls will ever like me. Those are cognitive distortions. We're going to talk about them as part of the treatment, okay? There's an assumption in the Beck model that early experiences provide the basis for these negative concepts and that they kind of just stay there harmlessly until some negative life event triggers them. So the TAD-CBT does use this Beck model as part of it when it does the cognitive elements. Okay, so hang on to that theory because we're going to use it to make up case formulations and to do the treatment. The second model is the Lewinson model, which is more behavioral. Depression is based on a lack of positive reinforcement, especially social reinforcement. Now, I remember reading this in graduate school and thinking this was about the dumbest thing I ever heard. It just didn't seem like it captured anything that felt like depression. Like, you know, if you're feeling down and blue and sad, I mean, who's thinking about positive social reinforcement, okay? But then I started to see that these guys are really onto something. Kids or adults who have limited social skills or don't get involved in pleasant activities don't give themselves an opportunity for positive reinforcement, so all the experience is negative reinforcement or the lack of positive reinforcement. Personality has three parts that we're going to use in the treatment plan. We explain this to kids at the beginning of the treatment, and we come back to it over and over again through the treatment. You can think of your personality as having thoughts, behaviors, and emotions, okay? And each one influences the other. So, to go back to the two examples, if the boy is overly sensitive to the girl not saying anything to him and starts to have all these negative thoughts, how might that affect his behavior in a depressive way? What might he start to do different behaviorally? Withdraw, right? Not try, okay? And how is that going to affect his mood? It's going to go down, right? And then how's that going to affect his thoughts? It just keeps going in a cycle, okay? Downward spiral, okay? So the treatment, here's the gist of the treatment. If I had to give a one-liner, the treatment is designed to change either the behavior or the thoughts so that it changes the emotions. You want to turn a downward spiral into an upward spiral. And to do that, the depressed person needs to learn new skills, either behavioral skills or cognitive skills. So here's the CBT model of treatment. First, the therapist works with the teenager to monitor the way they actually feel. Sometimes you can do this in one session. Sometimes you spend weeks on it. It depends on how well they can pay attention to the way they feel. Then the second thing is to learn the connections between different activities and the way they feel. So you do the behavioral part first. You look at getting them involved in more pleasant activities and noticing the connection between their involvement in a pleasant activity and their mood. You develop activity-related skills, which might be social skills, like how to start a conversation or how to stand up for yourself. Okay. The next part of the treatment is to learn how to do problem solving. So how to cope with stressful situations. And then the latter part of the treatment is the cognitive part. Learn the connection between thoughts and mood, and learn to challenge and modify your depressive thoughts. So it moves from behavioral to cognitive, okay? Now, I said earlier that we're going to talk about a case formulation approach. So the case formulation approach is what factors influence the depression in this particular case? What kind of skills or skill deficits does this particular person have? And given that we're working with kids, we also want to look at the family. What kind of family processes might be going on that contribute to depression? Okay?